Thank you very much. And thank you for coming and listening to me today. I wanted to acknowledge my co-authors, Bill McCarthy from University of Davis and Michael Jansen, who is here in the audience, and also the funding from CIHR. So what I'm going to do is talk a little bit about conceptualizing stigma and stigma power and its impact on health and also health behavior. A little bit about the limitations of some existing studies on what I'll term prostitution stigma, our comparative study, and some of our findings, and if I have time, I'll talk a little bit about limitations. So I'm sure all of you are familiar with Irving Goffman's description or definition of stigma, a deeply discrediting attribute for an individual or group. And in Goffman's term, any of us could be stigmatized. It depends on the context in which we find ourselves within society. And stigma is not something that's kind of it's a mark at the moment, but it actually varies depending on that context. Most recent literature, sociological literature that tries to conceptualize stigma and the stigma process is by Bruce Link and Joe Phelan. They've done a lot of research in this area. This is a recent table from one of their articles in Social Science and Medicine 2014, just published. And what they're trying to understand here, I think, is that there's negative cultural conceptions about a certain group of people or a certain attribute people may have, whether it be disability, whether it be people's racial characteristics, could be their gender and so on, or sexual orientation. And it leads to these daily indignities that people face in the contexts in which they find themselves, more severe in some places than others, maybe the workplace, less in family, and so on. But this leads to a concern about staying in. So people attempting to become conscious of the stigmatization, and they're trying to fit themselves in society, even though they're marked. So it leads to secrecy, concealment as much as you're able to, but of course you're always worried about being outed, and that's definitely the case in regard to the industry, sex industry. And then that has an impact on how you relate to other people, avoidance or withdrawal from relationships, and then psychologically this lower self-esteem, feeling of low self-worth, and what we call self-stigmatization. And that, in turn, it's not on this graph, but leads to particular health behaviors, which I want to talk about today. Now, Lincoln Phelan and others have examined the stigmatization process for a number of vulnerable populations, in particular people with mental health issues, but also people, sexual minorities, racial minorities, and so on. And today I want to talk a little bit about another minority group or stigmatized group, which is sex workers. So my question really is, what is this prostitution stigma, or sometimes referred to as the whore stigma, and how do we understand it, and then is it linked to health behaviors? Does it have a health impact? And in particular, I'm going to talk about drug use in my examination. So if you look at some of the limitations of other studies of stigma, you have to realize, prostitution stigma, excuse me, sex work is a very, very difficult area to study. There are no stats available on sex workers, and we have no really good idea of how many they are in a particular society, where they work, where they live, who they relate to, and so on. So very difficult. So there have been some studies on the impact of stigma on sex workers, but most of them rely on very small street-based samples, where increasingly in most countries around the world, sex workers do not work on the street, maybe 10%, 15% at most. So those studies are not that reliable. There are very few comparative studies comparing sex workers to other people who are trying to make a living. And that's really important, because otherwise we think the characteristics of sex workers are peculiar to themselves. There's also a failure to examine any mediating effects between, say, stigma excuse me, and a negative outcome like problematic drug use. And finally, there's a failure to do longitudinal studies. So following this group compared to other groups over time. Now you can imagine how difficult that can be to follow a vulnerable population over time, but we need to see what factor impacts, for example, drug use. So my colleagues and I have been working for a number of years now on a very large CIHR-funded grant, which first we had funding in Victoria, in British Columbia, and then we had subsequent funding in Sacramento to study the impact of stigma on marginalized populations' health and access to health services. So sex workers are our main population of interest, but we actually have comparative groups as well. So the study is longitudinal, and it involves face-to-face interviews, both with closed-ended measures and also a qualitative component, and we interview people over four points in time. So two groups work in the formal economy where there are statistical data on. That's people who work in restaurants serving alcohol, and then people who work as hairstylists. And then in the informal economy or shadow economy are sex workers that we interviewed. Why did we choose these? We've had so many questions about that over the years when we're trying to make sense of our data, but it's not difficult to have comparisons, but we did so not for the activity people are engaged in, but for their population characteristics. All three occupational groups do frontline service work. A high component of it is involving emotional labor, pleasing the client, making the client feel good so that they'll come back again, so that positive customer service. Predominantly female, as you'll see from our statistics. Anywhere between 75 to 85% of people in these occupations identify as female. Low barrier to entry to the work activities. There are no educational requirements to get into these particular activities. There are some certificates you could have and so on, but in neither country where we did the interviews were they required to actually have an educational certificate or diploma. And low, medium income servers and stylists in Canada make, in 2007 or so, they made about $25,000 a year. That's, of course, with tips not declared. And in our other studies of sex workers, they make about 25 or so thousand a year as well. So very low income among these three groups. So the data I'm talking about today, we're going to be using just under 600 usable interviews distributed among the three different groups. I could talk about the methodology to do this. It was quite complicated and multivariate, but we don't have time for that today, but I can ask questions. Yeah. So our hypothesis was really trying to understand the perception of prostitution stigma in particular, and we argue that we hypothesize that stigma mediates the relationship between sex work and socially less acceptable drugs, which I'll define in a minute. But that stigma does not really have a notable mediating effect on other more socially acceptable drugs. And so we had a number of standard measures for our closed-ended. We identified substance use on a continuum. So at the one end we have alcohol, which is quite normative in our society, and then we have marijuana, a little bit less normative, and then we have, over here we have less acceptable drugs, crack cocaine, heroin, and so on, and non-prescription use of drugs. So we're trying to get at the range of drug use and how society, because of course drug use is also stigmatized. And in regard to stigma, we had a number of measures of stigma. basically being refused housing even if you could afford it, had doctors and nurses who would say negative things about your occupation, believing that doctors and nurses didn't respect you, and so on and so forth. So we have a number of standard measures of stigma, which are close to the Lincoln-Phelan measures, and then a few of our own. So just want to give you quickly an overview. You'll see here from that sex workers don't really vary too much in regard to the gender breakdown or age, average age, but racial minority, sexual minority, they're more likely to be higher. They're more likely to be single. They're more likely to have a partner unemployed, and also to be currently living in poverty. And I want to, even though it's not here, I want to say that there's also a variation in regard to perception of stigma. So sex workers have a higher perception of stigma than the other two occupations. But what's real important is the other two occupations do perceive what you might call stigma low prestige. They feel put down sometimes in public. They feel that they've been not denied loans or access to housing, and sometimes they feel ridiculed by nurses and doctors. So there is variation in stigma among these groups. The other important issue, especially thinking about health disparities, is that sex workers also are worse off on most of the early childhood factors that we can think of in relationship to being in foster care, victim of crime, or any of the abuse level. And they also, even though they're not here currently, are worse off. You know, so their economic situation is lower. So what we wanted to do then, and this is our second wave. I know I didn't have a lot of time. So basically, what this regression shows is that stigma, which is measured here at the stigma, does not really have an effect on servers' use of drugs. In fact, servers compared to hairstylists use much more drugs, all kinds of drugs, right across. And what we see that when we bring in stigma doesn't impact the drug use of servers. It remains the same. But when we control for stigma in relationship to sex work, we notice that sex workers' use of non-normative drugs actually decreases. So we see then that there is a kind of mediating effect between the prostitution stigma and drug use, so it actually explains some of the drug use variation that we see among sex workers. So just to try to sum this up then, what we did see is that there is a link, a notable link between stigma and less acceptable, socially less acceptable drug use, and that controls as well for prior drug use. But stigma doesn't seem, perceived stigma reduces the association between sex work and less acceptable drug use, but that doesn't occur for servers in regard to their drug use. So their drug use stays the same. It does not mediate it by what they might call low prestige or the small stigma they experience. So I think what our study shows is that the perception of stigma or the perception of being discriminated against by others is one of the most powerful components of the stigmatization process that Lincoln-Phelan talk about, and it ties people into this web of stigmatization. Now, sex workers are also feeling stigmatized because of poverty and racial minority status and so on, so there are many operating stigmas occurring at this time, not just being in sex work or not just using problematic drug use. And so what I think we would conclude, or what we would point out, that stigma is not just a label, as Goffman talked about, and it's not just an individual process. It's not just something that others put on you. That actually, it's a structural process. Stigma really is structural violence. It's how we in our society look on others and we treat them, and it has tremendous consequences for their health behavior. And in further analysis, we'll take a look and see if that health behavior is also linked to mental health and well-being. Just a few weaknesses of the study. I think our measure of stigma could be a bit more verbose, and in a new study we're doing on the studying violence and resiliency of in the sex industry in Canada, we're using a more verbose measure of stigma, and so hopefully we'll try to see if it kind of holds up for the evidence I provided for you today. So thank you.
Thank you.